Good afternoon. Welcome, and thank you for joining the third meeting of the Interstate Telehealth Workgroup. My name is Kelly Scott, and I'm a program manager at the Maryland Healthcare Commission. I want to start out by saying this meeting is being recorded. Meeting materials can be found on the Interstate Telehealth Workgroup webpage on MHCC's website. A link to that webpage was included in the email I sent on Friday, and all meeting materials and recordings will be posted to that webpage. So before we get started, I just have some brief housekeeping items to cover. During the meeting, it's appreciated if you just keep your line muted if you're not speaking to avoid background noise. If you'd like to speak, just unmute yourself or use the raise hand function. If you have any issues with Zoom, please contact my colleague, Justine Springer. Her contact information is included in the chat. She's going to pop it in right now. And I believe our executive director, Ben Steffen, was called away to an unscheduled meeting. So I'm going to kick things off to David Sharp to make opening remarks.
Okay, very good, and good afternoon, everyone. We appreciate you all taking time out of your your busy schedules to join us today. Some of you are new to the call today, others of you are not. We'll be talking through what we call our information gathering tables as part of this discussion today, and we're really focusing in on what we would call potential, and I put that word in quotes, solutions to some of the challenges that relate to the specific questions at hand. And what you'll see is not an exclusive list, but what we've tried to do is show some of the items we think are up there towards the top if one were to organize the list in terms of highest to lowest. And what we want to do is get your all's thoughts as it relates to these items. And then we're going to circle back and talk a little bit about if we were to go with this particular list and each of the tables, who might be a good agency or organization to help advance these items. And I would note that we're not talking about every item in these tables being requiring legislation. Some might, others might not. There could be some policy issues related to different organizations that can be voluntarily adopted. But for the moment, we want to work through the list, identify the items that we think are relevant, and then add others that we think might be in the event that we haven't captured the spirit of what's here. I would sort of tip my hat and with a thank you to many of the representatives from not only the Board of Physicians, but the other boards who've been very instrumental in helping us pull together this table. The behavioral health folks specifically as well. We are meeting and talking with all of the boards. And so it's been a good experience. And there's a few participants here on this list of attendees today that have been uniquely called upon to help us formulate information we'll be talking about today. And to those, you know who you are, and we again thank you for the great work and ideas you put forth. So with that, Kelly, why don't we move into the discussion items? So let's just orient you a little to what you're seeing here. So what you have before you is what you'll see on each table, one overarching question that was included in the study letter we received, MHCC received from the chair of the HGO, Chair Delegate Pena Melnick last May. And what we'll do is we've tried to come up with what we think are key aspects of each question and then potential solutions. So I want to just pause and give you all a moment or two to read the items listed under coverage and liability considerations, as opposed to reading them to you. And then we begin to talk more about the column to the right, which is titled Solutions. Okay, so that said, if we turn to the column on the right side, Bullet 1, again, these aren't in any particular order, so please don't think that we're rank ordering here at this stage. The first item is consider minimum liability requirements for out-of-state providers that are not employed by an in-state hospital or facility. And I'll pause with each one of these for comments and reactions. Okay, while you're thinking, I'll keep moving through the list and then we can come back to each one of these. The next item, explore changes to network adequacy requirements and looking at Medicaid and commercial carriers to advance telehealth in workforce shortage areas. And Kelly, I'll rely on you for watching questions and chats. I do see something in the chat, so is it time?
It's just Justine's contact information right now,
Okay.
but I'll monitor.
Okay, thank you. And then the next item is expand provider and carrier consumer education and awareness of best practices and consideration for utilizing interstate telehealth. And then the following item, bolster provider awareness of malpractice protections for interstate telehealth if the out-of-state provider is out of network.
David, Paul Berman has his hand raised.
Very good, Dr. Berman.
Hey, thank you very much, Paul Berman from the Maryland Psychological Association. Thank you, of course, for reconvening. So is this, and I apologize for this question, may have already been answered, but is this assuming that the out-of-state practitioner who is practicing into Maryland is licensed in Maryland or is able to practice into Maryland because of a compact? So I mean, we're talking about liability, issues, malpractice issues, I guess. But it seems to me first question is, are they even able to practice into Maryland based on licensure issues?
So, Dr. Berman, are you, just to kind of hone in on your point, are you specifically referring to the first bullet, or is there a deeper one? And
yes.
And there's a reason for that. So,
yep.
Okay. So the first item is consider minimum liability requirements for out-of-state providers that are not employed by Maryland in-state hospital. So assuming that their interstate telehealth is possible, or imagine that it could happen for an out-of-state provider, the comment here is that there should be more evenness on liability requirements, because in certain instances, providers are not required to, not all licensing boards require providers to have a certain level of coverage, and the liability carriers don't have a minimum threshold either. So some of the concerns that were raised previously is that in the first column, particularly the last bullet point, that there's a sense of unevenness for provider liability insurance, which could create risks for the providers as well as consumers. So you have the premise here is that if the provider is assuming they're capable of performing because they're either licensed or they're they have reciprocity, whatever the board may have in place for that provider type, is that there should be more evenness around liability requirements.
Okay, thank you. But there only are, I mean, the only practitioners that I know of that are able to practice across state lines based on licensure would be, I guess, nurses, right? And physicians and psychologists if they participate in SIPAC. But so social workers don't have a compact that I'm aware of. The LCPCs are working on a compact, but I don't think that's off the ground yet.
Yeah, and Dr. Berman, you're raising good points, or you're absolutely correct, I should say. And when we get to the next question, we have the list of boards that
Perfect.
have compacts.
Sorry to jump ahead.
No worries.
Got it.
Thank you for helping us tee that up.
All right, thanks.
And
So-
David, Diana from MHA has in the chat, can you provide some further details on what kind of changes you have explored for network adequacy requirements in workforce shortage areas?
So, so I want to make sure I understand the question, Diana. So are you saying what we've already investigated, or are you saying what? Can you restate, help me understand, because the recommendation doesn't assume to this stage that there's been any research to say what's been done or not been done. What it's particularly talking about is looking at how looking at workforce shortage areas. So can you explain to me a little bit what you're looking at?
Sure. Thanks, David. I think my question is really, is there anything that you have looked at, as this solution was proposed? I think there's, questions about like, how would you identify workforce shortage areas? How would you, how you would leverage telehealth to help assist with that workforce shortage, because of course that's a huge priority for us. But then also on the overlay, there's there are most recently proposed network adequacy regulations from the Maryland Insurance Administration. So I was just curious if you could give us a little bit more of a thought process behind that solution and that proposal.
Yeah, so the idea here is that, again, going back to what can be a way to help address workforce shortage area challenges, and the feedback from the work group has been by some that interstate telehealth is a way to do that. Now, has there been carving up workforce shortage areas? I mean, we know that there's been lots of studies. There's the HSCRC has done some before. We have done some looking at workforce shortage areas. You can use ADI as a way to do this. You can, you coupled with census related and other demographics. So there's lots of ways to do this. The analysis hasn't been done. The first step is to assess the viability of this kind of recommendation.
Got it. And then for the actual, sorry, go ahead.
Oh, no worries, you're good. Go ahead.
And then with regards to, have you been working also with the MIA on some of the proposed regulations and how those may ultimately interact with this proposed solution?
So last year we had lots of conversations with some of the folks at the MIA regarding network adequacy. What we would hope to do is that assuming something like this were to proceed, that it would be viewed as a potential modification to what they're working on.
Okay. Got it. Thank you, David.
Sure.
David, Ellen Weber has her hand raised.
Hello, Ellen. Thanks for joining us.
Sure, thank you. Sorry, it took me a minute here. So I do have thanks to Diana for raising the MIA's network adequacy standards, because as everyone knows, those were just recently promulgated as a proposed rule, obviously after sort of a long 3-year process of working through things. And obviously there's been a lot of change over time, including a pandemic, which highlighted the difference, the different use for telehealth. But again, I think many of the comments that various groups have submitted, and we're happy to share if you don't have them, comments that the Legal Action Center developed along with a number of signatories from the Maryland Parity Coalition, which highlighted, some continuing and ongoing concerns, obviously. Among them, if you have interstate telehealth services where you have those individuals having no ability to provide in-person services in the state, then there will simply, there in our view, needs to be efforts made in which those telehealth providers are really developing relationships with providers that are in state and that are accessible to individuals, so that people who begin to use these services in a hybrid fashion, which many people will do, including many individuals with mental health and substance use disorders, they will then have available resources in a timely way and in an accessible way. To rely exclusively on a telehealth provider in that context, in our view, is just going to be an inappropriate way of addressing those needs. I think the other thing that we learned from the MIA's report is that carriers are developing telehealth only networks, and they're also developing products that are called virtual products that differ from telehealth services. And so those kinds of differentiation that are probably not at all understandable or transparent for consumers really need to be clarified. So your list of solutions to provide far greater education and awareness and far greater transparency requirements on the part of carriers, in our view, would be sort of critically important. And then the only other thing to identify is in Maryland, there is a provision on the law that really does prohibit telehealth only services for mental health and substance use disorders. And that's in order to be able to ensure that consumers really can direct their care. And we would urge that that type of standard still be retained.
Yeah, these are good points, and we're capturing them all behind. We have several note takers, and it's being recorded. Thank you, Ellen, for those good points. We don't imagine that this sort of support for network shortage areas would be a replacement to the provider. It would probably be in support of, and so you'll see suggestions as we go further down where it's more limited and there has to be more continuity of care, there has to be more communications. So providers who may be servicing these patients, providing care, when telehealth occurs, they have access to that information. But these are all great points. Thank you for bringing them up. Okay, other questions on what we have here? Okay. Seeing none, we'll go on to the second group of questions. Here again, same thing. Let's just take a few moments. And this, to Dr. Berman's point, provides the list of basically what we've taken from the website of compacts and where they are in Maryland. And if you could scroll down a little bit, Kelly, just there we go. Okay, and then to the column to the right, the first item is explore opportunities by oversight agencies to increase the licensure digitization process. Second item is foster the development of licensure by reciprocity agreements by select licensing boards and its use by the Maryland contiguous states. Should be contiguous states, so pardon the oversight. And then renew conversations with the District of Columbia in certain instances by select boards to advance compacts. And then the last item is to continue to promote the development of new pathways to licensure among select licensing boards. And let's pause here for a moment to see what you all might think. Is Daphne McLean?
Yes, hi. I'm the director of the Board of Social Work Examiners, and I'm sorry I have to leave to go attend the Health Occupation Subcommittee meeting, but I just wanted to say that there is a social work compact. It is in process. There's about a dozen states voting on it this year, but it was finished too late to be considered by the Maryland legislature. So I do anticipate that it quite possibly will be introduced in 2024 to our legislature.
Okay, we'll amend that. Thank you for the notation.
And I'm sorry not to stay very long.
No worries. Is there anything, Daphne, on the list here to the right that that you would say either causes any concern, or is that you feel these items are generally appropriate?
I think they're generally appropriate from our position.
Okay.
Thank you.
Oh, thank you for joining.
David, Robin, Elliot would like to speak.
Well, hello, Robin.
Hi, David. Good afternoon.
Good afternoon.
So when you said compact, I couldn't resist but raise my hand. So first, I want to thank you all so much for including the District of Columbia as an emphasis for our Maryland work. I've done compact work in DC, and it's definitely challenging. One of the big issues is that they do not participate in the nursing compact, which I am guessing creates a lot of challenges for a number of the different providers on the call. So I just wanted to thank you for that. The second, just to let everyone know that the last bullet under the solutions about new pathways to licensure, there's a lot of good work going on right now in a couple of the different workforce shortage groups. One of the main ones, the Commission on the Healthcare Workforce Shortage, that was a vital Kelly bill from last year. And so I think that we will see some recommendations coming out of these workforce shortage groups that might be of interest to this whole committee.
Yeah, and thanks, Robin. And also just to note that we appreciate your feedback on that. And on the next slide, you'll see that we think there needs to be, we can do some coordinating with this group as they're doing their work to be sure that there's some alignment as appropriate. And so we'll do our best to promote that, even though the report technically isn't due to the end of the year. But I think what you're suggesting is that more work we can do now, the better we'll be by the time we get to the end of the year and their report concludes. So, thank you.
Thank you.
So Deb, good afternoon.
Good afternoon. So I just want to make sure, I know that these are like snippets of concepts, but one of the things I raised last time was the new licensure pathway between DC, Maryland, and Virginia. And I just want to make sure that that's what you mean on the right side about continuing to promote the development of new pathways.
So it can mean, so I'll say, so yes and no, actually, it depends. By and large, there is the licensure by reciprocity that we'll talk about a little further here, and we noted above. But there's also some very creative approaches, and I would just note some of the work that the Maryland Board of Physicians has been doing. Is really laudable in that they've looked. There's even another category. It's licensure by endorsement, and what we're suggesting is that there continues to be this creative thinking approach to how licensure by each of the boards can either be modified, can be expanded. Whether it's to a contiguous state or somebody further, another state that may be further out. So we're not specifying for what purposes, but we're encouraging the continuation of thought. And that's what the group has largely settled on, because it doesn't seem like one approach works for everyone. It seems like there could be many different strategies, and depending upon the board, they could take a strategy that works most effectively for their members and of course their clientele.
I get that, but I still believe, I don't see it in your lists, and maybe it's someplace else, but I think it's something that shouldn't just be ignored. It should be one of the elements in here, only because it's our contiguous jurisdictions, and I think that's really important, and it's different than other states or jurisdictions that are not close. But so many Marylanders go to DC or Virginia for care. physicians and providers have practices in the 3 jurisdictions. I would just like to see, if you don't mind, even if
Okay.
it's on the left side, something that just recognizes that there is this subset.
Wonder. Go ahead. Go ahead, Deb.
That's all, that there's a subset in local jurisdictions to ensure there's some kind of reciprocity in those 3 contiguous jurisdictions. I just don't see it listed, and I would just like it to be recognized.
Yeah, can you scroll up, Kelly? I think you went down too far. I want to make sure, let's look at the bullet point on the second column, bullet point 2, to make sure, because I feel like you're saying this, but is that not, what would you change here? Because I sort of thought, as you're saying, I'm going, I think that's what the intent was behind the second bullet, but I may be mistaken.
David, if I could interject, this is Christine from Board of Physicians. I think what Deborah's saying is maybe to advance, instead of compacts, it would be reciprocity agreements. Because, like, for instance, Maryland, the Board of Physicians did a reciprocity agreement for physicians. But we still have more work to do with DC and Virginia, because we have 10 or 11 other licensure types. So there's always more work to be done. And I think it's my understanding DC reached out to all of the health occupation boards and said, hey, we've done this with the physician board. If you're interested, can we do this informational meeting? So I do think we are continuing to, look into reciprocity, and physician reciprocity with DC and Virginia was just the first step.
Okay, so let's see how let's try expanding the second bullet point, Kelly, on the right side.
Well, I think it's just that it's not to advance compacts, it's to advance reciprocity agreements, because reciprocity agreements are not a compact. We just have a memorandum of agreement with DC and Virginia that we will honor their licensees and they will honor ours. So it's a reciprocity agreement, not a compact.
So we should take out compacts and just call
At the end, yeah, I think it would be to advance reciprocity agreements.
Okay, and Deb, does that get to your point? To want to just make sure I don't step over it.
Everything that was just said, I totally agree with. Now let me see if I agree with the words on the page.
No worries.
And
you're doing this in track changes, right, Kelly, behind the scene? Just no markup. Okay.
I think it's the District of Columbia and Virginia. I don't need this to be so prescriptive, but that's what this is. And there's something appealing just to me to know. We don't know how far it's going to get, but I think those 3 jurisdictions make a lot of sense to have some sort of expedited reciprocity licensure process.
And that's a perfectly good point. We'll add it, but I'm curious from Dr. Berman, either you or Ellen, does this work for you, or should we make it more clear that this may be more specific to, say, a somatic provider as opposed to a behavioral health provider?
Certainly for them. Thank you. It certainly works for psychologists. I know our Board of Examiners has some very strong thoughts, strong feelings about reciprocity and concerns about it. Not to speak for them, but from the perspective of the Psychological Association, increasing access with bordering states makes sense to us.
Got it. And Ellen, your thoughts?
I don't have anything else to add to that, David. I've not been working really closely on any of these particular issues with regard to the board, so I don't know, or really the various professionals. I defer to Paul and obviously others who are working with social workers and licensed professional counselors.
Sure. And
again, the only other thing for me to say about that is, again, just keeping in mind that a lot of services are delivered for substance use and mental health services by certified practitioners, obviously, not just licensed practitioners, and how that I think happens in other states as well. And so I think that's one of the things to keep in mind when we're thinking about how to expand out the workforce. But I mean, again, I don't know how all of that slices one way or the other. I'm just putting that in as a note.
Hey, David, instead
Yeah.
of using the word foster,
Uh-huh.
I think because no one really knows much about this yet, I would suggest that we change it to explore again. It's something
Gotcha.
we should be thinking about and talking about, but not necessarily, we don't know what it really means yet. And so, thank you.
Absolutely, great point. This is kind of the eye checks we're hoping for from you all. So thank you so much. And Christine, could I just invite you to look at this one more time and tell me if you think we've captured everything from
I
your
keep telling
perspective?
you test my vision here. It's, yeah, I mean, it's reciprocity agreements. Yeah. And I think it should be all health occupation boards, really, not select licensing boards.
Okay, we can say that.
David,
Hey,
it's
Rob.
Robin. Hi, I think it's potentially thinking about an additional bullet.
Okay,
There is for compacts. So there is language in the 2020 telehealth bill that specifically asks the governor to promote the adoption of compacts in contiguous states.
so
So
we'll
I do agree with my colleagues that reciprocity is a different model. But sort of recognizing that compacts are also very useful. And then language of the 2020 law was contiguous states. So that was very important to the maker of that amendment, put that on, Senator Carrozza, to include like Pennsylvania, Delaware, and
So Kelly,
so
let's
it's a
add
large
a
group.
bullet point, and Robin, if you would just, restate again so we can dig around in here a bit.
Sure. It would be actively support the adoption of interstate licensure compacts in contiguous states to Maryland.
And I don't remember where that is in the statute. Do you, if you have that on the top of your head, we'll take that. If not, we can dig around.
Yes, it was in uncodified language at the end of the bill.
And what bill was it? You broke up.
It was the 2020 telehealth bill.
Okay. We'll pull it up.
Mm-hmm.
Thank you. This is great. That's looking good. All right. Any other comments for what we have here? Okay, we'll continue on. Question 3. We'll give you a moment if you could just again look at the items under licensure complexities. Okay, so the solutions, or at least potential, on the column to the right, allow select allied healthcare boards to consider implementing a telehealth registry. The next one, for purposes of continuity of care for existing patients, permit certain providers with an active license in another state to deliver telehealth services. And then, Diane, I'll come right back to you in just 1 second. The third, engage the Maryland Department of Veterans Affairs to address challenges related to the Maryland licensure requirements for military spouses and veterans. And this point goes back to the one Robin made earlier. Coordinate with existing efforts of the Commission to study the healthcare workforce crisis in Maryland. And this is the bill in 2021. So let me bounce back to Diana first and get your thoughts.
Thanks, David. So for the second bullet, I think we were wondering if, or rather, I was wondering if there's also a way to connect it to a nexus of existing health systems that are in Maryland. You know, in addition, so for example, this is looking at existing patients, but then, you know, we have certain situations where, you know, for example, many of our members also have hospitals in other states and may have specialists who are affiliated with the system and they'd like to refer for a referral via telehealth. And so we're wondering if there's any way to add some language about, you know, a nexus with, you know, with existing facilities and existing health systems beyond just, you know, existing patients, if that, or rather to sort of tie in existing patient for, they would be existing in Maryland with the hospital, but they might be new to the provider that's outside of Maryland.
So let's formulate probably, you know, a new bullet point 3. So let's add a new bullet point under the second one, Kelly, and let's see if we can figure out, because if you could just sort of help us bring to light a little more what you're thinking, because I kind of hear it, but I'm not sure I have it completely.
Sure. So I think it's more about, I think, and I have to also think about how to craft it, because I'm not very good at doing this stuff on the spot.
No worries. These are for individuals who are in Maryland that travel across state lines to see a provider that may be affiliated with maybe a Hopkins owned site in, I'm just making this up, in another state. But how would we do that? Because, and maybe this is where Christine can help us, because I thought we would be subject, the provider would then be subject to the laws of that state, and we wouldn't be able to say, either through law or policy or what have you, grant permissions to an in-state provider to provide services to a patient in another state, unless that state approved, you know, had a process to allow that to occur. Is that what you're saying, or am I just mistaken?
I think this kind of goes back to the question of whether we're talking about a two-way going, you know, services going out of Maryland or just services coming into Maryland. I think in your example, you're talking when we talk about this in an analogous way to like in-person services, it would be, you know, for example, so if somebody is seeing a provider in Baltimore and then they are referred to a facility that is in DC, that normally wouldn't be an issue. They would just drive down to DC or something like, or get down to DC in some other way. But then for telehealth, I'm wondering if there's a way for us to sort of bridge that divide. And I think I see a lot of hands, so I think people are helping me out here in maybe fleshing out this concept.
Well, if I could just ask, if Deb, if I could get you just to hold for a moment and see if either Matt or David can answer this question, or Christine, that would be great.
Yep.
Sure, and I assume that I'm probably going to say something very similar to David or Christine, but yeah, it's. I think that is a very relevant issue, and I think that's a very relevant point. But you know, when we are looking, we have no jurisdiction over services that are provided in another state, and that's typically determined, even in cases of telehealth, that's going to be determined based on where that patient is. So, you know, in a case like you're speaking, you know, we can talk about making rules and changes for incoming services, because that is where, you know, we have jurisdiction over the medical services that are provided to Maryland patients. And, you know, we don't have the ability to make a rule or you know, a law that would allow a Maryland doctor to provide those services outside of Maryland based on that jurisdiction. Now, what we can do, and what the Board of Physicians at least has been doing, has been working with, you know, nearby jurisdictions, in particular DC and Virginia, to start, you know, within the confines of existing law, to, you know, start establishing relationships so that we can have easier thoroughfare when you know, because patients do move between these jurisdictions, and they, you know, we have hospital systems that are across these same jurisdictions. And so that's certainly something that I think can and should be focused on. But again, there's no change that Maryland could make that would allow Maryland doctors to provide services out of state.
I think I've identified where I might have misspoken and caused some confusion. I'm talking about providers who are in DC giving a telehealth appointment to a Maryland patient. So that would allow us for our jurisdiction. So for example, that patient would be new to that DC doctor, but they would be an existing patient to the facility that they've been going to in Maryland. Does that make sense? So that's why I'm trying to sort of get that nexus.
Yes,
Okay,
so-
yeah, that I thought you were talking about services going the other direction.
No,
Sorry.
my mistake. I'm sorry. It's all this in and out stuff is very confusing. Yes. So I'm talking about services coming into Maryland, but where the patient is considered new to the outside, the external doctor.
So in this case, let's play with this for a moment. For the purpose of continuity of care, the issue here is permit providers with an active license in another state to deliver health services. So how is this different than Diana, what you were saying? For continuity of care, existing patients permitted with an active license in another state to deliver telehealth services. I'm not sure I follow you.
I think I'm trying to, so in my example, so the patient is being seen physically in person in Baltimore City, and then they need to get a specialist referral. Let's even go further. Let's say they have a specialist who's in Florida, who's great at this and is affiliated with the facility and is employed by the same health system, but is in Florida. So they would be a new patient to that Florida provider. And there's no way that they can drive down to Florida or something like that. But they'd be a new patient to that Florida provider, but they are an existing patient from Maryland. So that's what the distinction I'm trying to make is that maybe we could create a sort of nexus where if there is some type of a relationship between the existing provider and the new provider, for example, if they're employed by the same health system, et cetera, where it would allow for them to see the patient as a new patient, even though they'd be seeing them as a new patient, via telehealth.
Okay, so let me try tinkering with language and we'll go to David on this. So at the end of services, Kelly, put a semicolon, and then it would be allow a provider where an existing relationship exists with, we'll say for a moment, with an organization, or in this case, or an entity, to provide services to a new patient. And I know I'm just throwing your idea because I think that's what I heard you say. Now I probably needs wordsmithing, and David, maybe you can help us with that if you think this is right or it's permissive or something we could do or could be done.
I mean, the main issue here is just how do we make sure that that person is accountable to preferably the Board of Maryland if they are doing a bad job, if they have problems, if they're aren't meeting the standard of care, or if they're drinking on the job or whatever it is, whether or not they have a relationship with the patient or not, if they're not licensed, then the board can't do anything to them. So that's our concern, and I think that's I just want to for all of these things, for the registry, for the certain providers with active licenses, I think that there are certainly some situations where there's limited enough contact that it might make sense, but there are concerns. There are other countervailing concerns that we need to consider.
So is this, David, a perfect example of where if reciprocity existed, that was the other thing I was going to suggest for what Matt was saying. Matt's correct that we can't take action against someone from we can't force other states to do things, but that's why a reciprocity agreement is kind of the ideal, I think, here, because
regardless of whether they're in the other state or in this state and which way it's going, a reciprocity agreement kind of covers that in both directions. It makes sure that people who are, for citizens of other states who are seen by Maryland doctors, and for Maryland citizens who are being seen by doctors of other states, there's some sort of more formalized way of having some sort of licensure that protects against that, protects the citizens for that.
So Diana, does this help with understanding how that oversight element is a critical component to try to maintain?
David, I'm sorry, could I just interrupt just to say one brief thing that
Sure.
if the person is allowed to do telehealth, that means they can't do a physical exam or can't do a physical exam if required. So I do think that that has to be taken into consideration. You know, a telehealth registration or licensure might be great, but you know, we also have to think about what happens when the patient needs something more than just a telehealth visit.
Yeah, I hear. So it gets back to the things like for continuity of care to use telehealth. But if there's no relationship, it sounds like that's going to pose a challenge. And Diana, what are your thoughts here? I mean, do you still think that we've got to find a way around this, or you understand, does it make sense to you, or should it make sense that the oversight element is, and the ability, if necessary, to treat the patient in more of a physical environment is critical?
Well, I think that in terms of, that's where I think the nexus with having like the organization or the entity comes in, you know, the fact that if there is some type of like in-person, you know, some laying on of hands is required, the organization, you know, may be able to have somebody examine them in person while having the telehealth provider on the, you know, on the screen and things like that. And so it allows for that continuity of care, but also allows for an in-person component if necessary, you know, with existing clinicians. So I will say that I unfortunately don't have a solution for the oversight portion other than by somehow creating this nexus with an organization that exists in Maryland allows for at least some accountability, because there is an existing entity that has a presence here.
Yeah, so I think let's take this as a takeaway, because I feel that at least, you know, the pathways on the prior slide, when there was some feedback from the group about exploring alternate pathways to licensure by the boards being, you know, reciprocity or licensure by endorsement, or, you know, something of that nature, that an element of all things telehealth includes some aspect of a state, in this case Maryland, having the ability, as David mentioned, you know, if there's something bad that occurs, to be able to step in. And I think that's what I hear from.
Yeah, and I mean, if there's a nexus with the facility, then there should also be a nexus with the licensing board. Because I just don't think, I mean, you know, I'm not here representing the board members. Anything that I say is kind of my opinion.
Sure.
Based on being the executive director of the board. But I mean, of course, the board can override me, but I do think that the board strongly believes that some kind of regulation is required, you know, whether that's registration, licensure, something like that. But I do think that the board does support regulation, not just kind of like no oversight.
Okay. Okay, this is good discussion. Thank you. And let's see, Deb, you've been very patient, so I appreciate that. Kelly, you just want to behind the scenes mark this item for additional review so we can take more of a look at it. And then Ellen, is your thought of a continuation of this item?
Yeah, it's to identify something that probably many of us have been involved in over the last month, which is looking at the DEA's proposed rules with regard to the prescribing of both non-narcotic controlled substances as well as buprenorphine via telehealth. It's requiring inpatient examinations. I want to raise that as a point in connection with all of this.
Yeah, in fact, they've taken away some of the ability to use telehealth for
Right,
kind of
right,
prescribing, which
right.
was a shock to many of us actually. But your point does fit here when you put it in perspective. So that's a great thing to note for us. Thank you all. This is the kind of feedback we're hoping for, so we much appreciate it. Deb, appreciate your patience with us. What's your thoughts?
So just something, an overarching thought that I would be remiss if I don't say it. While we're only talking here about licensure, all the elements in these several of all the slides, they have to be looked at in its totality. Because while I can say, oh, this makes sense, but from a licensure perspective, the majority of people are going to have insurance coverage and are going to be expecting that their insurance will be covering these things. So in a vacuum, it may make sense to have all these reciprocity things and compacts and allowing people, like, you know, we were just talking about Diana once in terms of a Florida entity, but there needs to still that overarching element that the patient needs to understand that because there may be some flexibilities, that doesn't mean it's going to be covered in the way they expect it to be covered. And I just want I just need to say that so everybody understands. I don't, there has to be that expectation that if someone is not in the network, there could be an increased cost share or financial burden on individuals, even if we make all these flexibilities outside of the insurance arena.
Yeah, and we tried to do that. If you just scroll back to the first page, first question, Deb, you bring to light a great point. Maybe we just have to hit this one harder because we talk about when increasing awareness and education of what interstate telehealth means here.
Or like, for instance, notice to patients, because I do think Deborah makes a really valid point. I mean, if someone goes to a facility like Hopkins and they think that the Hopkins person from Florida is in network or whatever, they may not be. So I do think, and that's kind of where we're coming from a little bit, because then we'll get a consumer complaint and we won't have, if it was allowed, we wouldn't have any authority to do anything. We'd have to tell that consumer, oh, you know, the person kind of practiced here via telemedicine and we have no authority. And I think it would be very frustrating to Maryland citizens.
Yeah, why don't we, just for purposes of putting a placeholder here, Kelly, why don't you semicolon put, maybe we'll just say strong notification or clear notification to, why don't we just say clear notification to consumers?
And so, David, if I can just jump back in, the thing I'm really worried about is I know this talks about provider and carrier consumer education, but a lot of times the carrier has no clue until the provider has already performed the service and we get a claim. So I really want to focus on the fact that if the provider or the entity, the facility, or whoever somehow can make that connection of the insurance coverage, that patient's going to have no idea until after the fact, and that's really problematic. So
let's do another bullet here. Just hit return, Kelly. I think Deb's point is a good one. Let's figure out how we can capture it. So it's provider awareness that I think you're saying that regarding, is it provider awareness regarding?
It's not even an awareness, David. Honestly, it's a requirement. Like, I don't want them just to be aware, because we're aware of stuff every day, all of us, so it doesn't mean we do something about it, right? And so, like, I'm sure there's going to be resistance from a lot of people in this call, and we can come up with better ways of thinking it through. But it's really, there has to be some way that the patient knows in advance that they may be going out of network, and there may be ramifications based on their insurance coverage.
So does it require providers to provide a notification to patients or consumers, whatever you want to say, when they're, regardless of their, maybe it's of their carrier participation status in network / out of network. Is that
and potential cost
liability.
impacts or something.
Okay. And cost sharing impact.
Yeah.
That's okay. So let's look at this and see if we got what you were saying. I think that's an excellent point.
I think out of pocket might be better than cost sharing, because if it's out of network, they might not share at all.
Got it.
That's fair.
And then take out cost sharing and just say out of pocket. Excellent. Oh, even the dog agrees. Okay. Does this come? So Deb, you're comfortable here?
Until I hear what others are going to say. But yes, I just think it's really important for, they're all looked at separately, and we may decide from a pure licensure perspective that the boards are comfortable going in one direction. And I don't have a position on that, but there will be a consequence from an insurance perspective. And I just want to make sure people understand what that potential consequence it is.
Got it. Let's see what Dr. Berman and then Ellen has to say.
Yeah, no, I agree with everything that's been said. The problem from the practitioner side is it's very hard to get that kind of, well, it's one thing to say practitioner is obligated or required to inform patient clients that there may be financial responsibilities that are or that they're impacted. Then, of course, the obvious question is then the client's going to say, how can I find out, or can you find out? And that's where it gets very complicated, because often you can call an insurance company and they will say, we don't know, right? We just don't know because for whatever reason. So, having an obligation or requirement to say it may be impacted makes sense. But there should be some way in the system to be able to help the patient figure out what the impact may be.
So Dr. Berman, maybe Deb can jump in here for a moment. If a practitioner knows for sure they're not participating, don't they generally know? There's difference between I know I'm in network, I know I'm out of network, versus will that service be covered? And are you talking about will the service be covered, or the distinction between I'm in or I'm not in that network?
I'm talking about something slightly different.
Okay.
So I can, if I'm providing services to somebody in Maryland and I am sitting in Maryland and I am out of network, I typically know what the copay is going to be for the cost sharing for the patient. But if I am sitting in DC and providing services to somebody in Maryland, it's hard for me then to know what the impact is of me sitting in DC is going to have on insurance coverage. So it's not just out of network, but it's out of network and where you're providing the services that may also impact the reimbursement.
So Deb, before we get to Ellen, your thoughts on what Dr.
Yeah,
Berman?
look, I tend to agree. Dr. Berman's right. All I'm asking is the following.
Okay.
If somebody's seeing is at a Hopkins facility, using Diana's example, and they want to refer them to a Florida practitioner via telehealth, Hopkins should be telling them there's a possibility that this provider is not in your network, and you should really check with your carrier to make sure what your financial obligation is going to be. And additionally, if someone's looking at a registry or they're looking to see somebody out of state, there should be some kind of notice or something. And I guess we can't require those out-of-state providers unless there is some sort of reciprocity requirement to actually tell the patient before they're seen, you need to check with your carrier, your Medicaid carrier, your commercial carrier, whatever it is, to determine whether or not you are going to have some sort of out-of-pocket expense. I don't think anybody would actually know what that is.
Right.
So that's where I'm saying Dr. Berman's right about that, but there's got to be some way that somebody knows before they actually go for that appointment that they're going someplace where there may be an additional cost. And the only person that can tell them that is the provider or the facility, because they're the only ones that know that this is occurring before the carrier gets a claim.
Okay, I think we can play around with this a little bit. I hear you and I hear Dr. Berman. Let's see, Ellen, did you have any other changes you want here? And
Well, I don't know if there are any changes, but it's the same issue, and trying to figure out the relationship between what a registry is and what a carrier's directory is. And it's the directory, as well as the electronic directory, that patients very frequently go to figure out who's in network and who's not in network. And so that obviously puts a highlighted need, to the extent that we're doing this, on accuracy of those directories, them being up to date, and figuring out who bears the burden of an inaccurate directory. So
That's not what I'm, Ellen, if you don't mind, that doesn't help. I totally agree with you that directories have to be up to date. But when a doctor says, hey, I want to send you to so-and-so, that doctor should be obligated to say, but you better check with your carrier to make sure you have coverage. Some will have coverage. They have PPO coverage, and they have coverage to go out of network. So you wouldn't see that in your directory, but that doesn't mean they're not going to have a higher cost share. So I hear you, but that's not what I think I'm trying to talk about at all. In terms of a directory, if somebody's telling you should go someplace else, or that the state has some sort of a blessing that this person is part of a compact or a registry, there should be a warning that people know you better check with your carrier, because you might have benefits and you might not.
And I don't disagree with that. What I am saying, though, is in addition to that, because it overlaps with these other issues. And that's the thing that I think we also have to keep into mind. That's all. Because there are ways in which patients figure out the answer to that question in response to what Dr. Berman said. How do patients figure this out? Well, they go through a variety of steps, one of which is looking at electronic directories. If those directories are not up to date, if they don't identify any number of points, then that a patient isn't going to know, and it's going to be very difficult for them to figure that out. So I'm adding that as an additional point to keep in mind.
yeah, and that's well taken. Thank you. So I think David Finkler is going to make a comment.
I actually had a question for the two I think the two doctors. I'm not sure if you both are doctors. I'm going to assume you're doctors. Is this insurance issue a factor, whether or not? I mean, would this be a problem if they were licensed within the state? Is this a registry problem, or is this a problem regardless? Because that could just be a reason why we should have, perhaps an easier licensure process, but not go the registry route. And I'm not sure if this is something that is irregardless of registry versus license or not.
So if I may, Paul Berman, this is an issue of, pardon the informality, of where my butt is sitting. It's not a licensure issue. So if I could be licensed in Maryland and in North Carolina, and seeing someone from North Carolina into Maryland, and I can see them, but because I'm sitting in North Carolina and the patient is sitting in Maryland, there is the possibility, if not likelihood, that services are going to be provided are not going to be covered. I could participate with Cigna in North Carolina, but that doesn't mean participating with Cigna in Maryland. So it gets very complicated with the carriers when you're sitting in a different state.
Yeah, that is true. And that is true. There's not going to be a foolproof answer for that, because you brought up a very good point. But I think providing consumers with enough information to arm them to know where to go for these answers is probably the best we'll end up doing. And Deb, I don't know if you had your hand up for something else here, or you just hadn't put it down yet.
I put it down. I'm done for now. Thank you.
Okay, so we have a couple things here to chew on. Let me see. Are there any other thoughts as it relates to the conversation we just added that resulted in this bullet? Okay, so why don't we go back to Kelly, where we were? Okay, so are there, the last item we left off was one that Robin had given us a prior notion, a hint on as it relates to the work that's going on based on House Bill 625 and actually I think it's Senate bill. So Kelly, I think we have 2 HBs, so we'll need to correct that. And I don't know if Robin, you want to jump in here and help us out?
Sure. So this is a issue that comes up a lot for nurses, which is why I know a lot about it, but it also affects other professions. And that is, how do we support people in the military who are transitioning out, as well as their spouses, in becoming licensed, any type of licensure. It also includes licenses under dollar. So there was a report, a very thorough report about 10 years ago, looking at some of the specific areas where military members didn't quite meet civilian requirements. And it was a very thorough report. And as a result, because so much work had been done already, this issue came up again a couple years ago. And as a result, then Delegate Kelly and Senator Bidle put it in their legislation. And it's actually, the bill is of 2022, sorry. And this existing workforce shortage commission for healthcare is going to be looking at this. And in short, at least in terms of nurses, it looks at medics and corpsmen and recommends them kind of going into the field of EMTs under MEMS, as well as getting a head start in their nursing education program. They can get some credits and in there, either if they want to become an LPN or an RN. So I'm happy to talk more about this, but in essence, I wanted to flag this because I didn't think this group, you have so many other bullets on the list, didn't necessarily have to reinvent the wheel on this.
Very good. Thank you, Robin. So other comments here related to the items on Q3? Okay, hearing none, we'll go on to the next one. And like the others, if you can take a few moments to read the column on the left side. Okay, and then we'll talk briefly about the potential solutions here. So the first one is consider including the use of electronic health information exchange, except where prohibited by law, as part of select professions standard of care. The next item, explore opportunities to include a safe harbor in value-based care models where care quality and costs provided outside of the medical home to attributed patients do not adversely impact participating providers. And then the last item, assess implementing requirements for telehealth only technology vendors that operate in Maryland to exchange electronic health information with a state registered health information exchange. In this case, someone like Chris. So let me pause here and see what you all think. Rob,
Just a question. How much does the CARES Act kind of address this issue of interoperability? And does the state need to take any action, or will the federal rules make some of this a moot point eventually when things are being enforced and implemented?
so under the information blocking component, there are roughly, I believe it's 7 categories where information blocking can fall under regulations once they're promulgated by CMS for the CARES Act, the information blocking. And the way it's structured is that the technology vendor can't deny sending information based upon a request. But that's more on an individual basis. What we're proposing here is to put, instead of a reactionary process, to put in place a proactive solution that allows technology to just interoperate with each other without needing to have any additional activities underway. Much like today happens with the hospitals in Maryland that are already connected, and so many physicians that are as well, and other healthcare providers is equally, where that information just flows. It's like the spigot's been opened and the data flows. So I think, Robin, to your question is, might it step its toe in the water and address some of this potentially? I wouldn't say no, but I think having a much more fluid and active interoperable system is probably a better strategy, and for whatever that's worth, but just something to think about. And we have some hands, so I think I saw Diana's first.
Thanks, David. So about bullet number 3, how, when you're talking like exchanging electronic information with say CRISP, how much information would be exchanged? Because I'm thinking about, for these telehealth only vendors and organizations, if we're trying to create a bridge between them and say that there's somebody who's in Maryland seeks help from one of these technology only vendors or telehealth only vendors, but then really needs to be referred to a local provider for services, how much information are they going to be able to pull from CRISP, and then how much information are they going to have to request from that telehealth only vendor?
So let me try to answer reversing it. So if the vendor itself is integrated with your example, Chris, just like Cerner, their Epic, Cerner is Epic with their solution, Greenway, SureScripts, the data from that individual when treated, if the patient is seen in a telehealth environment someplace else, but lives in Maryland, that technology vendor integrated to CRISP, if Dr. Jones at the University of Maryland decides to try to find information on that patient's visit with that out-of-state, with that telehealth provider would be available to that treating provider. It could be a summary of care, it could be medication history, it could be any kind of referrals or follow-ups. So it would be based upon what the provider needs, much like exists today. When they go into CRISP, they're saying, oh, let me see the last 3 labs that you've had, and one of them were ordered by somebody else, they would see that.
All right, thank you.
You bet. Deb.
2 things.
Okay.
First is this, if it was discussed before, I don't remember, but the last bullet you have on both the left and the right side, actually the last bullet on the left side, second bullet on the right side, I need to take that back to my folks. So I would like to stick a pin in it from my perspective as a carrier who's been involved in value-based care arrangements, just to understand how we envision models as it relates to telehealth. because I have no idea. So I'd just like to ask for a little indulgence and time to check with that. And I'd like to try to explore a little bit more about the first bullet on the left. And I don't know the answer, but I think that's a really big, important point, that we don't want to lose information back to the medical home or the primary care doctor or the primary doctor that they're seeing for some specialty, because they got a service someplace else out of state and we lose track of the data. I don't know if there's other ways to be creative, since we don't have really authority over those providers. And so if we're looking at any types of reciprocity again, or in the compacts, maybe Robin knows this, or if we have some kind of linking so that that we say, yeah, you're on our list. Can there be a requirement, or is there a requirement they've got to give that information back to the patient's primary physician or the physician that they're primarily under the care with, so that information comes back?
Well, let's let Robin go and then I'll jump in. Robin.
That's a good question. So for compacts, that's uniform model language. And so you can't really add stuff to it in terms of a requirement if somebody was practicing in Maryland through a compact. And so all the compacts are set up in the same way. There'd have to be another mechanism.
And the other mechanism, to Deb, your point, to Robin's point, is if you require the technology that's being used when that patient is seen by that provider to be integrated with an HIE, then it's available to the medical home provider, Deb, to your point, that wants to find out where I've been seen recently. So that was the basis for that third recommendation under the solutions category, because the best way to do that is to have technology that's interoperable. And
but what's there to require that physician or provider to ever send the information back?
So if the solution is connected, it's not a push model. So it means that because they're connected, when the medical home doc goes into, and I'll pick on Chris, and decides to look up a person, it goes to any place that person's name and their demographics has been seen. If one of those locations is in Utah, and I'm just making that up, it will show the care summary and what was done at that location. So that doesn't require that physician in Utah to hit send, because that solution is already connected. And does that help, or did it just confuse?
I don't know. I mean, you know way more about this than I do, David, so I will defer to you. I just didn't know if all providers and all specialties are linked in some way that their information can get back.
Not 100% on the ambulatory provider on the outpatient setting is not connected yet to specifically Chris, but most of them are connected to an HIE, and the HIEs are supposed to be connecting based upon legislation to Chris. So eventually you get that interoperable, plus there's the national networks. The trick is, and there aren't that many, but they're just enough to be thorny, that have not connected with an HIE. And that's the group you want to get to if you want to achieve what you noted as the first bullet point on the left. So I think that's something we have to think about. And I just want to come back to your point about the second bullet point that you mentioned on the right. I think certainly putting a placeholder to revisit, but what we've heard from so many providers, particularly in the MDPCP, and those who are participating in other carrier models or are starting to participate more, is that there's a fear that as telehealth becomes more built into the fabric of care delivery, that being responsible of David's practice, I have all these patients attributed to me. And it turns out when I get my, my bonus, we'll just call it that. All of a sudden I get a downside share as opposed to a positive share because the care of, 5 patients was through the roof someplace else. And I had no idea about it. But because they're attributed to my panel, there's a potential, and maybe it's not in the Care First patient-centered medical home model, there's a potential that I could be dinged for it if I'm someplace else. And what the providers are saying is we'd like to have some protection because we can control what we know, but if the patient goes outside of our medical home and gets care, because they could have, they could be seeing anyone for that matter. We just want to make sure that in some ways it doesn't come back to negatively affect our attribution list. So that
I totally understand that. That doesn't mean that, and I understand that fear, and it's intellectually, totally get it. But I don't know what our contracts say. I don't know what we've negotiated. I don't know what the vision is in the future. And I'd really like an opportunity just to hear another side of this issue that I may come back and say, oh, we're totally in agreement. Or I might have something that's novel and interesting to say, I hope. So I'm just asking for a little bit of time on it. That's all.
Absolutely.
Thank you.
You bet. Janet, your thoughts?
So what I'm wondering about, I'm speaking from the position of a social worker.
Okay.
Where does a patient's right to privacy and consent come into this information sharing?
Excellent question. So consumers have the right to opt out of this. I mean, there's just no, consumers can say, I can actively block my information. And that happens. I think Chris, by way of example, has, out of all the providers that participate, they have somewhere around 10,000 opt-outs. And, but when you think of in Maryland alone, the 6 million, 5.8 to 6 million people, the opt-outs are smaller. And under the way the law is structured, some services, even without the consumer opting out, are prohibited from being shared with an HIE, Chris. So there are those services the consumer can say no to. And there are those services that exist in statute that consumers don't have to say anything. It's just blocked from being shared.
And how would a consumer know that they have that option? Because it's an opt-out, not an opt-in, right?
Yeah, it's an opt-out nationally. I think there's maybe 1 state, maybe 2 that still have opt-ins, but the information sharing has been structured as an opt-out. The providers are supposed to, and what we know that hospitals, and Diana can help speak to that, and they do a good job educating the consumers of what information sharing means and how they can opt out. And we hear from practices they do that as well, particularly those in primary care. We hear a lot, but I don't want to leave out specialists either, but I just hear a lot from primary care.
One somewhat unrelated question, but before I was a social worker, I was a math person. So what about the question of the more things are connected, the more hackable they are?
Well, I think that's true in any industry, but what I can say is in healthcare, the privacy and security requirements are elevated significantly above what might exist in other industries. And there are, if you think about it, you don't hear a lot. I mean, these large breaches get to the media. We audit and they're required to report to the state when there are breaches. And you don't hear many breaches really. There are, and I would not minimize that. There are some, but you don't hear it a lot. And if you listen to the news, you're probably more likely to hear another industry that gets hacked than in the healthcare industry. They're protections are extreme, but there is nothing, I'm here to say, I don't think there's ever going to be 100% on anything. Your banking, if you go online to the hardware store and provide them information, Amazon, I mean, but you don't hear a lot, but but healthcare does a really good job of keeping the protections extremely high. I mean, putting in place some technology that keeps the protections high.
Okay, so there's no attempt to have various well, I'm not going to put this well, but when you do research of various kinds, right, there are ways to protect with certain kinds of coding or anonymization or whatever. That's not what's going to happen in a medical record, right? So,
well, it is when the law requires today, when the law requires that certain services, certain medications not be reported, that has to be implemented because they will be service-based. And in Maryland, the Secretary of Health has a group that will be impaneled later this year to look at how it can grow, if you will, expand beyond what may exist today. But typically beyond when it's a requirement in law or as designated by the Secretary of Health, what then happens is it's an opt-out from the consumer standpoint. And in the future, today on the consumer standpoint, it's either you're all in or you're all out. But in the future, when it's not required by law, the industry, healthcare industry, not just Maryland, is working towards what they call granular consumer consent, where if I wanted to opt out because I didn't want Dr. X to have any of my information, I can do that at one place, and that blocks Dr. X. If I didn't want someone else to know of a particular service or medication, providing it's not a CDS drug, controlled dangerous substance, which law states require reporting, most states, I would be able to do that. But that's a slow process to come about. The healthcare industry's been talking about that for 10 years. And it's slowly starting to come into the horizon, but it's probably another 5 years out before you get that kind of consumer control. But in Maryland, there's laws that require or prohibit sharing of select information.
okay, so, but from a timing perspective, you wouldn't have this kind of sharing of information depend on having that implemented.
Well, keep in mind that information sharing has been going on for a decade now, and that it's already in play. And the only thing that consumers have ever been able to do is say I'm in or I'm out, and that's not just in Maryland; that's anywhere. And but in time there will be granularity, but there's also certain services that are blocked. So you couldn't. There's not an ability to wait to say there should be no information sharing until the consumers can have granular consent control. The providers have spoke loudly against those kinds of models consistently for more than a decade. The research is just abundant why that's not a good idea. And remember, when health information exchange was born, it was under the premise that people are dying unnecessarily. And the way you promote that, the way you guard against that, is you allow treating providers to have information related for an individual to provide appropriate, timely, and safe care delivery. And so that was really the premise of launching health technology into the future and put us there.
Well, I take your point. My population, we have to have a lot of consent forms signed. We have a lot of restrictions on who we can share information with. We need detailed consent. And so that's the perspective I'm coming from.
Understood.
This is not being restricted to medical data sharing. So,
understood.
Well, thank you for such a detailed and responsive answer. Thank
No, and great question. We always appreciate that. And I think, Robin, did you want to follow up with anything?
Just kind of dovetailing with what you were saying, David, and to let Janet know that I'm very happy to also chat offline. In one of my roles as a reproductive health advocate, I worked with the Maryland Healthcare Commission this session, and Maryland will be the first state to put in place specific protections for data sharing around reproductive health because of the criminalization of abortion care in multiple states. And so I just wanted to raise that. Thank you, Janet, for raising this issue of data privacy. And I think because of Maryland's work and including the healthcare commission's really very specific work on implementing this reproductive health privacy, that we are really in Maryland on the cusp of truly being able to empower consumers to have more control over their data. And so I know there are a lot of steps to go to get there. Dr. Sharp mentioned them, but I wanted to say that Maryland's probably the furthest along than any other state in the country. And so thank you for raising the issue. And so I think it's a really important one.
Yeah.
Thank you so much for offering me that possibility. I appreciate it.
And there's also restrictions on what can be shared electronically through SAMHSA, the Substance Abuse Confidentiality Regulations. And there's also limitations under HIPAA about what behavioral health information can be shared. For example, the psychotherapy notes. There's some limitations on what can flow through an HIE, and HIEs have built that protection most notably around other requirements of SAMHSA. So it is there, and I think you do bring to light good points. I just wanted to give you some assurances, and what I think Robin is doing as well, that there are some protections in place around that. So are there other questions on or comments on this slide? Okay, so why don't we go back to the very first slide if we can. What I'd like to ask is just hypotheticals now, and it will help us. If we were to say, let's go to number one, Kelly, not number two. Okay. If we were looking at and saying, assuming for the moment that these seem like reasonable suggestions, there's the notion of, is this legislation? Does this require legislation? Or does it require policy change? Or both? So if we could just take a look at each one, and we'd like to get some thoughts on it. We have about 20 minutes left, and I'd like to just see what you all are thinking here. So on the first one, we said consider minimum liability requirements for out-of-state providers that are not employed by an in-state hospital facility. Would this in and of itself, do you believe, require legislation? Or is it just a policy change amongst providers? It feels like to me this would be a legislative requirement, and something more granularly may fall under the MIA. Is there any disagreement? Folks think we're on the right track. I'm on the right track with that suggestion. Ellen, your thoughts?
Yeah, no, I think you're absolutely right, David. I think the one thing that I want to just raise here is I would put a footnote in there that any of those kinds of requirements have to comply with the Parity Act, the Mental Health Parity and Addiction Equity Act. I mean, we have seen different types of liability requirements imposed on mental health and substance use disorder providers that work through their insurance, right? To the extent insurance is wrapped into any of this, then I think we have to be aware of that. Insurance may not be, but to the extent it is, that's something that I just want to put a pin on.
Okay, so Kelly, if you put brackets here and put legislation, and then Ellen, we want to follow up with you afterwards, because we'll go back and listen to what you said, but I want to make sure you mentioned something, and I want to make sure we appropriately capture that.
I do have a question though. Sorry, I didn't get my hand up quick enough.
No,
I've
no
lost my patience. Sorry. I was good before, David. I don't understand how you do that.
How you do what?
How do you put legislation in on out-of-state providers?
So couldn't necessarily say without talking to the MIA, how that might work, but my sense is that, this is something they probably had to think about in the past. And, why we're saying that it's let's say it's here, it doesn't mean that it's achievable, it's doable, but it means that we wanted to go back, we'll go back to the MIA and say, to your question, how would you do that? And if they came back and said, oh, here's how, then we'd say, okay, something like this could remain. And they said it's impossible, then we would have to take it out.
Why do you think this would be MIA? This is about licensure requirement, liability requirements. That's, to me, that sounds like licensure requirements. That's not the MIA. So that's why I'm wondering.
Fair enough. Go ahead.
Robert Barron from the MIA here. Sorry the way I sound, I'm under the weather.
Oh, I'm sorry. Thank you for joining.
So there's truth to both sides here. Putting minimum liability requirements in place on anybody would not necessarily be an MIA thing, because we don't do that. That would be more of a licensure thing. But there's no malpractice liability insurance requirements for any providers here in Maryland, and I think probably in many other states. So you'd probably need to wrap that into both spheres, a licensing piece and a legislative piece that would require, so these practitioners who are out of state, if they want to be licensed in Maryland and there is a minimum liability requirement in statute, then we would have a piece of that action in terms of enforcing the somebody obtaining the liability cover.
So why don't we put in where it says legislation, maybe we'll just put a paren within there and just say, licensing, and again, it's just sort of a placeholder for us to talk more about. And Dr. Berman, were you going to say something?
No, I'm with you, David. I think it's a licensing issue, and the board, a board does have, I believe, does have the authority. If someone's practicing into Maryland, they can write in regulation that you need to have certain requirements for malpractice, and you need to be allowed to practice based upon requirements set forth by whatever the Board of Examiners is.
Very good, thank you. Robin.
Yeah. Just to make it fun, I'm going to throw in, I don't think it's a licensure issue. A couple reasons. The first being, well, first, it might have to be on both in-state and out-of-state providers. Having differential requirements may violate licensure compacts. The second reason is that a number of different providers are not the ones who carry liability insurance. So a physician, unless they own their own practice, is not going to be the one carrying their insurance. And then most of the other types of providers are insured under their facility. And then the third reason I'll just flag is this would be an enormous shift for licensure boards to implement. And so we just want to kind of think about, are there other ways to potentially look at this issue outside of a licensure requirement?
Yeah, I think that if you're in, and by the way of the example, if you're in-state if working with an in-state hospital facility, they, they carry liability coverage. But if you're self-employed, I think that's what you're saying, but I think Robin, you're suggesting that it be more related to just general legislation around liability coverage if you're a self-employed practitioner.
I will give an example of why I think this tying it to licensure may have very serious unintended consequences. Let's say you are a nurse and you are working for a private practice. Let's say your private practice loses its medical malpractice, or you switch to another employer who doesn't have it. I mean, in the meantime, that nurse cannot practice until the board has processed the paperwork. I mean, I think there's some incredibly serious implications in terms of the licensure process and having gaps in care, which we already have huge workforce shortages. So I think as we explore this deeper, and keep in mind, this is all the boards, not just physicians, that there may be some very significant infrastructure issues with putting in around the licensure.
So if we take out the licensure and just said legislation, would that address where I think I hear you saying, Robin?
I guess, I mean, I think this group or whichever group ends up working on this, I just wanted to caution, I don't think it's a foregone conclusion that you hang it on as a licensure requirement because of all the complications, and that we really have to look further.
So we'll make a note behind the scene to come back to this one. What about on the next item, explore changes to network adequacy requirements? I feel like that would be whatever changes that came about, where the requirement to do so would be a legislative one. Is that fair to say?
No.
No.
I think it depends. I'll defer to Deb. She had her hand up.
Yeah.
No, I sort of spoke without my hand up. So this is something, I mean, I really believe this is something that for 3 years we've been working through the MIA, who does have the authority to be looking at network adequacy requirements and have been looking at telehealth. And so I think they have the authority today. I don't think there needs to be legislation.
So you're saying regulation.
I'm sorry?
You're suggesting regulation.
That's right.
Got it.
I think they have existing authority today and we don't need legislation here.
It's a great point. Diana, were you going to say that too?
Pretty much. Just to again reemphasize that the proposed regulations are currently, under. I think the comment period ended last week, but there are existing proposed regulations that many of us have submitted comments on, and many of them are specifically with regards to telehealth. So just reemphasizing that collaboration and checking in with the MIA.
Yeah, and we have Robert, so we'll have a conversation with him post this meeting. Then traveling along on the next item. So if our choices, let's throw regulation to the choice as well. So there's the legislative regulation, there's policy. Any thoughts? Deb?
I think this could be policy. I think that this is.
Okay. Diane, we'll add that in brackets. Deb, you had a comment?
I think it might need legislation if we're going to be requiring some type of education to make sure it actually happens. I don't know exactly what it would look like at this point, but that there was a true requirement that a notice be given, even if it's a generic one, honoring what Dr. Berman said before, that a provider doesn't know exactly what it's going to be, but that there is some sort of requirement that they're told when you get referred to an out-of-state telehealth provider, you should check with your carrier or something. Know that you may have additional costs.
Understood. Diana, you were going to follow up on that?
Yeah, I think I would also, so if it's not policy, then I would also urge us to look at existing laws, for example, like the No Surprises Act, and other existing state requirements, to see what type of disclosure already exists and whether this actually might already be addressed in some of those existing laws.
Interesting. Okay. So we'll put a note there for that. Next item, which was an addition. And maybe.
Hey, David, I do have one question.
Sure.
I'm sorry, I do. And this is a question to the boards. Through policy and requirements for licensure, can that be a licensure requirement or something that the boards require as opposed to legislation?
And I think Christine or David, are you still here?
Can you explain what you mean by that?
That part of a requirement, the board, I don't know if it's possible. I was just trying to think of a way that was non-legislative. Can it be part of the regulatory
You're
process?
talking about adding requirements for.
Yeah, the notice, some kind of notice that providers are required to give if someone's going to be going out of network. I mean, obviously we can't make a requirement you all can't make a requirement on that Minnesota provider who is seeing Maryland resident, but at least those who are making referrals or.
I don't know what authority we would have to add something like that in. I'd have to look into it. I'm not really sure exactly how the board would be getting involved in it. Like the board doesn't really get into the granularity so much of, like, patient consent is not something directly that the board, does. It's just a standard of care issue in general. I guess I'm not prepared to answer. But I think it's a tricky thing for the board to start enforcing. I mean, the board does enforce consent if you don't have patient consent. You're not following the standard of care, but I'm gonna have to get back to you on that.
Okay, thank you. We'll make a note for David. We'll follow up with us. So on to the next one. Provider awareness, bolstering provider awareness and malpractice protections for interstate telehealth. Any thoughts? So I don't know. I mean, so I would just guess that the way to make sure that some level of awareness happens is through legislation. Don't know how we would do this through policy. So I look to others to course correct me here.
David, just out of curiosity, do we have, I know previously we've had representation from MedMutual and the doctor's company on the line. Have they joined today? Just because there's a lot of discussion about malpractice, and I'm not sure if we can answer that without them.
So they have seen the material, but and to my knowledge, they're not on the call with us today. And Kelly, you can correct me if I'm wrong.
I do see Derek Yarmus on the call. I'm not sure if he's available to speak right now.
Derek, are you able to weigh in on Diana's question?
He may have stepped away.
Yeah, so no worries. We'll circle back with the folks from MedMal carriers. But we've been fortunate to get their engagement on the material, so that is if that helps to know.
Great. Yeah, just because this is completely out of my expertise. And so I
Understood.
was just curious if we had them on the line.
So why don't we put just as a placeholder legislative, because I would not know how you would effectively do it without it. And then again,
David, there's nothing on the fourth bullet. Did you want to fill that in or not?
yeah, okay. Thanks, Deb. And then on the last item here, opportunities to address challenges related to provider credentialing. I feel like this is going to be the boards, if would anyone disagree? And this could be regulation, I guess I would say.
David, it's Robin. I think this may be, I think this is insurance credentialing.
Oh, you're absolutely right. My bad.
Yeah,
Yes.
which would be,
Would
of
be
course,
regulation.
our carrier partners and the MCOs and,
Yes.
I think we need to explore this more because I didn't understand that. And we really didn't talk about this one. And I'm not sure what we're supposed to do about out-of-state providers and credentialing.
Well, I think so. I can share we can put a question mark here, Kelly, but I would say that the thinking was from providers is that the credentialing process, not by everybody, but it varies. And in some cases, it's
Did we lose David or did I lose David?
David, I think you might have muted yourself.
Yeah, no, I think he's frozen.
He looks frozen.
Oh, he may have, we may have lost internet at the MHCC office.
Oh, he was just at a good point.
somehow
hey, Deb.
There, I hear him now. He's back.
Oh, we lost you, David. We didn't hear anything you said.
Oh, geez. Unstable connection. No worries. Robin, do you want to fill in?
Oh, yeah, it was just, I wanted to flag for Deb that there had been an issue with telehealth providers from out of state enrolling in Medicaid through the ePrep system. I think it's more or less been fixed, but that is something potentially to follow up on. And a lot of the discussion has to do with if you have an address, whether or not it's an in-state or out-of-state address. So I do not know if there is an equivalent with CAQH, but agree with you that there probably needs a lot more discussion before delving into.
Thank you for saying that. Can we add a little bit to this so we understand it's Medicaid and it's exactly what you said about ePrep or whatever? Because I think that this is way too broad in light of what you just described.
That's not the only issue, though.
Laura, but who was speaking to that, Laura?
That was Laura. Yes. I brought it up at the last meeting because there are different credentialing requirements, even in state, for those that are seeing children versus adults. And I don't know that that's the case in other states. So if we're doing compacts with other states, then we need to know what their requirements are, which rules they have to follow. So there's some concern there for me.
So is this, but you're saying this is an all carrier situation, Laura? You're saying,
Yes, yes. Even private insurance, everybody. Even if they change from one office of the same entity, let's say Jewish Social Service Agency, they change from one office to the other, they have to go through the whole thing again, the credentialing. And for the youth, it takes a very long time if they're seeing youth because of the background checks and all the other things that it's very different than if they're seeing an adult. It's much easier to change even locations. So now we're talking about out of state from anywhere. What does that look like?
So I think it's not just Medicaid. It sounds like Deb, Laura suggesting it.
We're not going to be credentialing out-of-state providers. So I understand. I don't think this is, I don't really understand the issue, to be quite honest. It's the first time I'm hearing about this. However, in the bigger picture of what I'm hearing, this issue that we're discussing today, the core foundation is what to do in terms of expanding telehealth to out-of-state providers. That is different. If there's an issue with credentialing in general, that's one thing. But the fact that we're talking about out-of-state providers, which I believe is what the topic is here, credentialing is not part of that conversation in my mind, because we don't credential out-of-state providers.
How are you going to cover them under your insurance plan if
That's
you're
the
not
whole
credentialing
point.
them?
Correct. That's the entire point of what we said earlier. We don't have national networks. When you're an HMO, you have a local network. And so this is part of the problem why we were discussing bullet 4 above to talk about the out-of-pocket costs. That's one of the biggest problems. It's, you know, when you look at something just from a licensure perspective, that's in and of itself great. You can have all these other people make sure that there's the ability to see outside of the state, but that impacts networks and that impacts what someone's purchased and what's going to actually be covered. So
I'm not clear what you're saying at all. I don't know of any insurance provider that covers mental health or substance use care in particular without credentialing the doctor. If we're doing a compact so that you can have providers from out of state provide services to Marylanders that expect to have it covered under their insurance, then they have to be credentialed.
there are two separate things. I'm sorry. I was trying to explain that before. Just because someone's licensed, that doesn't mean that they're in a network.
Okay, I think this is helpful. It is 2 minutes before the hour, so I think what we should do is pause here. Huge round of applause to everyone sticking in here and all the great comments. It was very useful to us. What we will do is we'll send out an email regarding next steps. What we might ask you all to do or consider doing is, as we've thrown in some labels here for each of these items, we might ask that you just give us your best attempt to identify, and we would articulate this in an email, if it's legislative, if it's regulatory, or if it's policy. And let's just see what folks think. And it should be a quick, easy, hopefully it won't take too much of your time to go through and identify what your thoughts are around that. We have a few takeaways we need to work on, and we have some cleaning up that you all engaged us with, and we're very appreciative of that. We'll also look to see, when we can meet again, but we'd like to use some of the responses and the feedback you've given us to let us work through that, and then we'll identify the next meeting date. I would imagine it would either be late April or early May at this point, but ideally, if we can connect later this month, and that would keep the ball rolling for everyone. So with that, I will conclude it here. Again, thank you all, and we appreciate your time today, and we look forward to talking to you soon.
Thanks, everyone.